Hello, my name is Professor Mark Wilcox. I'm a medical microbiologist, MD trained, practicing in Leeds in the north of England. And I see my particular specialty is C. diff infection and healthcare associated infection. So at this particular meeting in Vienna, I've been involved in several symposia, which I just wanted to give you some highlights of what I've presented. And I'd start with a symposium about fidaxomicin and presenting data summarising how fidaxomicin achieves the reduction in C. diff recurrence that we see with patients treated with this C. diff drug. And actually what it appears is there's a number of potential different mechanisms, particularly including the absorption of fidaxomicin onto the surface of C. diff spores. And this appears to be able to prevent fidaxomicin germinating and outgrowing from the surface of the spores. One of the other symposia I've been involved in is presenting data about beslatoximab, which is an exciting new human monoclonal antibody against one of the major toxins, toxin B, that causes C. diff infection. And not only have we been discussing the clinical data that was published in the New England Journal of Medicine 2 or 3 months ago, but we've presented some new data from those clinical trials looking at patients, a subgroup of patients treated with beslatoximab who also had inflammatory bowel disease in addition to C. diff infection. And these are a very difficult group of patients to treat with uncertainty about just how much the C. diff infection is contributing to the disease. But also they traditionally respond poorly to C. diff treatment. And the good news here is that when we look at the cohort of patients with inflammatory bowel disease from the phase 3 studies, is that they appeared to respond just as well as those without inflammatory bowel disease. Now the patient numbers are quite small, so we can't definitively conclude that beslatoximab is efficacious or as efficacious in these patients, but the preliminary data look very promising for the use of this human monoclonal antibody in those difficult to treat patients. Thirdly, another symposium that I've been involved in is discussing the 5th generation cephalosporin, ceftaroline, which is an anti-MRSA cephalosporin. And whilst there's lots of interest about the use of this cephalosporin to treat MRSA, which you can't do with any other cephalosporins, intriguingly, some of the most powerful clinical data about the use of this drug is its activity against pneumococci. And actually it's in studies, in 3 phase 3 studies that have been performed now in patients with community-acquired pneumonia, the studies were powered to show non-inferiority against the comparator, ceftriaxone, and in actual fact, each of the 3 studies demonstrated superiority. So it appears that this 5th generation cephalosporin does genuinely have superior clinical efficacy in patients with severe community-acquired pneumonia. And those are probably the main highlights of the work that I've been involved with here at ESCMID in Vienna.
Okay. Thank you very much.